So let's continue our discussion on hepatitis C, the most common bloodborne infection in the United States. It's currently recognized that about 7.5 million people are infected with this virus. Most of those who have been infected were born between 1945 and 1965, although those who are IV drug abusers or have exposure to blood products of those who are infected may also be at risk of the infection. Only about 50% of people are aware that they have hepatitis C currently. And in the 1980s, treatment began using interferon. That was followed by the addition of interferon and ribavirin and something called pegylated interferon. Now, there were problems with this therapy. It only was effective in approximately 50% of individuals who had the disease, and it varied depending on the type of virus that you had. The problems were that there were significant adverse events that might occur, that the treatment was not always effective, and that there were contraindications to the treatment. So many people that could undergo therapy were not able to be treated at the time, or they relapsed or did not respond to treatment. Now, there's 6 major genotypes of this virus, and it's a highly variable virus. It exists in many different species, which made it all the more difficult to treat. The genotypes 1A and 1B are the most prevalent in the United States. And the most important factors for treatment turned out to be the degree of fibrosis or scar tissue in the liver, and also the viral load. A viral load of less than 600,000 was considered to be more treatable. The genotype was also very important for that as well. Now, the triple therapy came out more recently using a drug called telaprevir or boceprevir in combination with the PEG and ribavirin. This is the first generation direct-acting antiviral agents, and in combination with the PEG and ribavirin, these other newer agents increased the rate at which people would respond to therapy dramatically, but they still had all the side effects that occurred with taking the pegylated interferon and the ribavirin, which primarily is anemia and viral flu-like symptoms. Now, more recently, there have been 3 new classes of drugs that are being approved, and there are many drugs in the pipeline for hepatitis C. The advantages of these drugs are that the dosing is less number of pills per day, and the adverse events and risk factors are much lower, and the chance of a cure is significantly higher. These drugs exist in 3 classes called protease inhibitors, and one drug was just approved called cimeprevir, polymerase inhibitors, and a drug called sofosbuvir was just approved for that, and something called NS5A replication inhibitors. Now, these new second-generation drugs are very effective in the treatment of hepatitis C, but currently they can't be combined as of yet in an all-oral, non-injection regimen, which is the holy grail for treatment of hepatitis C. So the regimens that we have still predominantly require you to take the pegylated interferon and ribavirin, although the course of treatment has been halved or even made much shorter than that, as short as 12 weeks. And some genotypes will respond just to the oral medication alone. So we stand at the threshold of new therapy for hepatitis C. So the question is, should we treat now or should we wait for treatment? And this timing of treatment is not a straightforward question. The recommendation is primarily based on the degree of scar tissue or fibrosis that we see in the liver, and we can determine that either with a liver biopsy or now with some non-invasive tests, such as a blood test or a special test which measures the elasticity in the liver. Now, the risk factors for more rapid progression of the disease include age after 40 years, male sex, excessive alcohol consumption, and co-infection with other types of viruses such as HIV or hepatitis B, fatty liver, or immunosuppression. In patients with minimal scar tissue in the liver, treatment can be safely deferred, however, until the time that we have better therapy, and patients may be better off deferring as one option for their treatment. This is something that you need to discuss with your liver specialist. Very important. And the promise of these drugs is materializing, but there are still some unknowns that we still have to work out with this newer treatment. Now, this whole treatment paradigm has been shifting for years and will likely remain very much in flux over the last decade, so it's important that you find someone who has experience in treating hepatitis C and discuss this carefully with them. And the treatment regimens that we have are rapidly changing, and they're going to significantly improve the landscape and the ability to cure people with hepatitis C. So there's great hope for people with this disease, and it looks like we may be able to cure the vast majority of people safely and effectively with minimal side effects in the near future. Thank you.